Visible?
Yeah, you can proceed. Yeah.
Good morning, everyone. I would like to thank AIOS and Johnson & Johnson for giving me this opportunity today. So I'd like to share my experience with this new monofocal IOL that is available, the Eyhance by Johnson & Johnson. This allows us to improve spectacle independence for our patients who are undergoing cataract surgery. So our visual requirements today are very different from what they were only a few decades ago. Far more activities today are dependent on intermediate or even near vision. So today spectacle independent vision for distance after cataract surgery is just taken for granted. Everybody expects that. But now more and more patients are demanding adequate intermediate and near vision without glasses after surgery. Now, many tasks which require intermediate vision in our daily life can be activities such as cooking, driving a car so that you can see the dashboard on the car, if you are into playing any kind of musical instruments as hobbies are picking up, and most importantly, all of us who spend a lot of time on computer screens. Now, with the pandemic over the last 2 years taking more and more of our life and our activities online, this desire for better spectacle independent near and intermediate vision is greater than ever. Now, there are numerous premium presbyopia correcting options that are available, which we can offer to our patients, but most of them come with different limitations. Most significant being the photic phenomena that can lead to dissatisfied patients. And also these IOLs have a long list of relative contraindications. They also carry a significant premium in terms of cost, which not all patients would be able to afford. Now, preoperative counseling for these patients becomes a very tedious process because you are explaining the possibility of photic phenomena, and it's very crucial to explain that preoperatively, but it also makes patients very hesitant. Monovision, on the other hand, is a good option for a small proportion of patients because the loss of binocularity means that they would still need to use correction in certain situations requiring good stereopsis, such as if you're driving on the highway over a long time. Now, what if you could provide something better to your risk-averse patients? So a newer generation of enhanced monofocal IOLs claims to provide improved intermediate vision by simply increasing the asphericity of the interior surface of the lens. So on gross examination, the Eyhance appears like any other monofocal IOL. The process of loading, injecting the IOL, even the biometry and IOL power calculation is the same as with a standard monofocal IOL. So it eliminates the need for any kind of learning curve. Preclinical trials have also shown that the lens has the same tolerance to decentration as any other monofocal IOL, meaning even for younger, relatively newer surgeons, it is a good tool. And again, we can see that even on a red glow, it appears no different from a monofocal IOL. So Dr. Tonieto et al. Used surface profilrometry to determine the superficial profile of the Eyhance IOL and compared it with other standard monofocal IOLs, including the Tecnis 1. So in this figure from this study, we can see the profiles of two standard monofocal IOLs compared with the Eyhance IOL. No obvious difference can be appreciated in the line representation of the Eyhance and the Tecnis 1. However, after removal of the best fit circle from the raw profiles, the differences in the interior surface become appreciable. Now, as expected, the standard monofocal IOL showed flat subtraction lines, meaning that in the central 2.5 millimeters, the profile of the IOL was perfectly circular. Now, the higher order sphericity of the interior surface of the Eyhance is visible because as it's visible as a progressive, smooth altitudinal change of only around 4 microns in the central 1 millimeter of the lens. So what about my experience with the Eyhance? Now, I've been implanting this lens since September 2019. And rather than position this lens as a premium alternative to any other aspheric lens, we have moved entirely from the Tecnis 1 to Eyhance. In my perspective, it simplifies the preoperative counseling and the IOL selection from the patient's perspective. So in our data of 116 consecutive eyes, of which 71 were implanted with the Eyhance, we can see on the plotted defocus curve that the Eyhance matches the Tecnis 1 at distance and then maintains an edge above the Tecnis 1 for the entire range from intermediate till near. Now, the Eyhance provides better uncorrected intermediate vision and near visual acuity, and the difference was statistically significant. Dr. Minucci's publication reported a better intermediate visual acuity in patients with bilateral IC2 versus the Tecnis 1. They observed no statistical difference in contrast sensitivity between the two groups. And their binocular defocus curve was similar to the one we also published, in which the eye hands achieved a smoother profile along the entire curve and showed significantly better defocus curves at simulated intermediate vision between -1 and -1.5 diopters of defocus. Now, this is a questionnaire used by Poyelis et al. To help assess the quality of vision after implantation of extended depth of focus IOLs. We deployed it in our practice to help us analyze the quality of vision in patients implanted with the Eyehance IOL. Now, results from the questionnaire showed slightly better scores with the Eyehance across majority of the different questions, particularly when asked about satisfaction with near and intermediate vision. However, on the questions on night driving and just general vision during the daytime, the Technis One did edge out over the Eyehance. Now, in Dr. Minucci's study, the patients were administered the patient-reported spectacle independence questionnaire, and only 20% of patients in the Eyehance group reported the need for intermediate correction in their everyday life, whereas 90% of the Technis One group required glasses for everyday intermediate vision tasks. So what are the advantages? So now, unlike multifocal or EDOF lenses, there are no restrictions in patient selection. It can be implanted in patients who have a normal monofocal in the other eye. If you implanted both the eyes, you have the advantage of binocular summation versus if you were looking at monovision in the same, even micro monovision. It has the same A constant as the Technis One, so transition for power calculation is absolutely seamless. It simplifies preoperative counseling and IOL selection for a patient. What are the limitations as of now? The major one is that there is no toric correction available in our country as of yet, but is expected very soon. The other challenge can be setting appropriate expectations for your patients. When you try to explain that this gives you better intermediate vision, but not necessarily better near vision, it is important to use maybe a few examples and illustrate that, because many patients will tend to be unsatisfied with the near vision. They assume that this is a lens that is correcting near vision also, but it is important to clarify that to the patient. So the takeaways are that this is a lens that can potentially redefine the standard of care for visual rehabilitation after cataract surgery. It is not something that is groundbreaking. It's not something necessarily that is entirely new. It's more like a transition from, if you go from an iPhone 10 to an iPhone XS, it's not an iPhone 10 to an iPhone 11, which is something completely new, a completely new generation. It's a gradual progress, but it actually can have a very profound impact on our surgical results over a larger scale. It does provide improved independence from glasses for many daily tasks for our risk-averse patients. Thank you.